Okay, so as I said earlier, let's say that there's renal ischemia. How? Elderly patient, male, approximately 45 years of age. Obese. Without a doubt, you're thinking what, please? Good. Atherosclerosis. Young female, 37 years of age. Not obese. Not hyperlipidemia. Lipid profile, perfect. But, you do a renal angiogram. What's that mean? You're actually checking out the renal arteries. And in there, you ended up finding a beaded appearance in a young female, 30 years of age. Where am I? Renal artery. What does that mean in terms of perfusion to the kidney and the glomerulus? Decreased. What's this called? Renal ischemia. What receptor do you have in juxtaglomerular apparatus, please? Beta 1. Good. You have beta 1 receptors. Are they stimulated? Yes, they are. Just like the heart. What's beta 1 mean to you? Catecholamine. Here in the juxtaglomerular apparatus, the beta 1 receptors have been stimulated. Why, please? Renal ischemia. Why, please? Ask yourself the question, why, every single time. And you get your answer. Absolutely you will. Because you've asked a fundamental question. And at some point, you will find the answer that everyone is satisfied with. Let it be the patient. Let it be a question. Let it be an attending. Whomever it may be. But now, you have renal ischemia due to atherosclerosis, maybe fibromuscular dysplasia, what have you. You have increase in renin. You continue. Increase in angiotensin. 1. You go up into lungs, don't you? What enzyme do you have there, please? ACE. What are you going to create? Angiotensin 2. What are we trying to do? We have decreased perfusion to the kidney. Specifically, you increase the angiotensin 2. Are we done? No. But what do you know about angiotensin 2, please? Angiotensin 2 causes vasoconstriction everywhere, globally. But if it is down in your glomerulus, where does angiotensin 2 love to act? The efferent arteriole is its preference. Is that clear? The efferent arteriole. Are you picturing that? The efferent arteriole. Remember in physiology, the efferent arteriole, if it underwent a vasoconstriction, what then happens to the hydrostatic pressure over the glomerulus? Good. You increase the hydrostatic pressure over the glomerulus. What are you trying to do? You're trying to restore that GFR, glomerular filtration rate, because it had an initial decrease. Why? Because of renal ischemia. Are you putting things together? Do you understand this is not just pathology? This is medicine. This is not just pathology. This is not just a subject. It's the concept of medicine. And you need to bring everything together so that you connect the dots so that you're able to walk through this particular journey. Now, with angiotensin 2, it may cause a direct vasoconstriction, or it may then actually work on the PCT so that it reabsorbs the sodium. In addition to that, what else does it do? Angiotensin 2 works on the adrenal cortex. Really? Are you picturing that? Adrenal cortex. What are the layers? GFR. How convenient is that? We have GFR referring to the kidney. We have GFR in the adrenal cortex. But the GFR in adrenal cortex stands for glomerulosa fasciculata reticularis. You learned that from physio already, and anatomy, every other subject that you've already looked at. So here, I want you to focus upon the glomerulosa. You ready? Glomerulosa. You automatically, reflexively are telling me what hormone? Aldosterone. Good. Guess what's responsible for releasing or forming your aldosterone? Angiotensin 2. What does aldosterone do? Are you with me? Where are you now? Aldosterone. I want you to go to the collecting duct. What are we trying to do? With aldosterone, you're going to reabsorb sodium. My goodness gracious, you're reabsorbing a lot of sodium. What is that going to do to your blood pressure? Aha! Secondary hypertension, huh? Secondary hypertension, all because you caused renal ischemia. Why? If it's a young female, what's my diagnosis? Most likely, please. Good. Fibromuscular dysplasia. If it's an elderly male, atherosclerosis. Good job. Let's continue. All right, here it is. You see that arrow right there? What's that look like? Does it look like atherosclerosis to you? My goodness, no. That's beaded appearance, isn't it? It looks like a string of beads that you may wear around your neck right now. You see that necklace that you have on your neck? That's a beaded appearance. Yeah, there it is. But where am I? This is not around your neck. It's your renal artery. Wow. It's undergoing dysplasia. In what patient? Young female. What do you think has happened to the caliber of that renal artery? It's decreasing. The renal artery. What happens to perfusion in the kidney? Decrease. What's that called? Renal ischemia. What are you going to do to JGA? Stimulate. What's a receptor? Beta 1 receptor. What are you releasing? Renin. We just talked about all this. Renin does what? Angiotensin 1, angiotensin 2, angiotensin 2. What does it do? Vasoconstriction. Take a look at that algorithm we just went through. Angiotensin 2 has direct vasoconstricting activity. It also increases aldosterone, also reabsorbs sodium. Diagnosis number 1. Diagnosis number 2. Atheromatous disease. You think athero. Please focus upon athero. Athero. What's that mean? Why do I want you to focus on that? Because I don't want you to get this confused with arterial. Is that clear? Read my lips. Arterial versus athero. How important is that? Ridiculously important. Athero means lipid. As soon as you hear athero, it's lipid. Arterial, generic. Clear? You don't know what's causing the constriction in arterial. It could be a lipid, granted. It could be, yes, but it doesn't have to be. Really, what else could it be in arterial? Could be hyaline, as we'll talk about later, called hyaline arteriolosclerosis, or hyperplastic. But here, specifically athero, lipid. What's going on? Who's your patient? Most likely male, obese, older, 45, 50. Clear? Renal artery, same story that we just did with fibromuscular dysplasia. But before we move on, a huge point. Clinically, every single licensing exam is going to ask you this question, and you should be quite aware. Why is it that you have to avoid ACE inhibitors big time? See that being bolded right here? It's important. Walk you through this real quick. Atherosclerosis is taking place in the renal artery. What happens in perfusion to the kidney, please? Decreased. What happens to GFR, please? Decreased. GFR is decreased. What does that mean to you? As soon as you hear GFR decreasing, it means that you're probably going into renal failure. You want to do everything in your power to make sure that you restore that GFR. Can you do that for me? Can you do that with ACE inhibitor? Are you kidding me? Think about this, please. You just released angiotensin II. Where does angiotensin II prefer to work? Good. It prefers to work on the efferent arteriole so that you can restore your GFR. But what if you're giving this patient an ACE inhibitor in the setting of atherosclerosis? You have just completely inhibited the formation of your angiotensin II. Why would you want to do that in this patient when the kidneys are trying to be protected? So therefore, it is contraindicated in this patient. Is that clear? Now, give me where an ACE inhibitor would be the first line of treatment, or call it, quote-unquote, renal protective, in diabetes. In diabetes mellitus, ACE inhibitor is the first thing that you want to give if a patient comes in with microalbuminuria. I will repeat this. Don't worry. I'll repeat this so many different times that it'll be part of your unconscious reflex. That's what I like to call it. You're sleeping there, and guess what? You're going to wake up and think, wow, ACE inhibitor and diabetes. Good to go. ACE inhibitor and atherosclerosis, oh, contraindicated. Cannot have it. Where did you hear that? Right here. Ha-ha, let's go. Now, renal parenchyma disease. What are we talking about here? Let's talk about PKD, polycystic kidney disease. As soon as you hear this, we'll talk about this in nephrology. And it's the fact that you have autosomal dominant polycystic kidney disease. That's one I want you to focus upon. You should be able to quickly tell me the gene with that. Remember, all we're doing here is review. But it's also important that you make sure that you connect the dots very quickly. 85% of your patients with polycystic kidney disease, autosomal dominant type, is PKD1. Is that clear? As soon as you hear about PKD1, what might you be thinking about this in patient? What aneurysm was that up in your head? It was called a Berry aneurysm. Good. What's another name for Berry, please, clinically? Saccular. Good. So saccular aneurysm is being formed in PKD. Why? It's not because you have cysts in the circle of Willis. That makes no sense. The cysts were located down the kidney, usually bilateral, right? Most likely an adult. But you still have to call it autosomal dominant. Is that clear? Do not call this adult. You'll miss every single question. You'll disappoint your attending. You don't want to do that. Trust me, you don't want to do that. This is autosomal dominant. You have cysts in the kidney resulting in hypertension. Do not equate polycystic kidney disease to renal failure immediately. Is that clear? They're two different entities. What did you say, Dr. Raj? I said, do not equate polycystic kidney disease with the renal failure immediately. They're two different diagnoses. Could you go into renal failure with polycystic kidney disease? Yes, you can. Immediately? No. It's insidious. What's that mean? It takes a long time before you actually go into renal failure. Is that clear? All right. Now, with that said, with PKD, you have hypertension. What kind? Secondary. May result in Berry aneurysm, amongst other things. Diabetes mellitus. Once again, what's that going to cause? It's called non-enzymatic glycosylation, right? NEG. Or some of you might have heard of it as being advanced glycosylated end products. What's going to happen to your blood vessel? Specifically down in your arteriole. It might undergo closure. It might undergo, once again, closure in which you may result in secondary hypertension. Important diagnoses and differentials under secondary hypertension. Is that clear? And at this point, all we've looked at is pretty much the kidney, renovascular hypertension, secondary.